We'd like to get a more detailed MRI protocol consisting of 3D, heavily T2-weighted, meaning really focusing on the fluid signal, fast suppressed imaging that allows us to scrutinize the dura, the nerve root sleeves where many of these leaks can occur, and subtle findings related to perhaps a prior iatrogenic, doctor-caused injury, a tiny irregularity where a needle may have been, some very subtle fluid, and so on and so forth.
Welcome to Frame by Frame, Rethink Imaging, a podcast by Immunologics. Here, we explore the intricate world of medical imaging, aiming to dissect the field and inspire both professionals and curious minds alike. I'm your host, Chris St. John. Today on Frame by Frame Rethink Imaging, I am joined by Dr. Andrew Callen, Associate Professor of Radiology and Neurology at the University of Colorado School of Medicine. Dr. Callen is the founder and director of the CSF Leak Program, the first multidisciplinary center in Colorado dedicated to diagnosing and treating spinal CSF leaks. He has published more than 60 manuscripts, invented a novel patent positioning device for dynamic CT myelography, and serves on the medical advisory boards for both the U.S. and Canadian Spinal CSF Leak Foundations. He also directs the annual Spinal CSF Leak Bridging the Gap conference, which uniquely integrates patient stories with physician expertise to advance care. Welcome to Frame by Frame, Dr. Callen.
Thanks for having me. Happy to be here.
It's so good to have you here. And I just said a bunch of information about you and your bio, talking about CSF leaks, right? So before we dive too far in and to catch me and potentially our listeners up, can we just start with the basics? What is cerebrospinal fluid and what role does it really play in the brain and the spine before we talk about leakage?
Yeah, that's a good place to start. You could think of CSF, cerebrospinal fluid, as sort of the brain's natural cushion and plumbing system. So the brain and spinal cord are floating in this fluid. It is encased in a lining called the dura. And, it's more recently, sort of in medical science, we've come to realize that it's more than just a cushioning system. It's actually a very, very important part of the way that the brain and spinal cord function. It's involved in several metabolic processes, waste clearance, and I think that's a good way to summarize it.
Okay. And so just moving right on to the leakage, what is happening that is causing these leakages before we touch on how to find them?
Yeah. I think a good way to sort of start this discussion is to start with just something that people are more familiar with, I think, which is a spinal tap, right? A spinal tap where a doctor puts a needle into the spine to sample some of that fluid for somebody who, they think might have meningitis, for example. Doctors have known about CSF leaks in that context for a long time. They recognize that when we took that fluid out of someone's spine, they would sometimes get a headache. And it was a very characteristic headache, a headache that felt better when they were laying flat and worse when they stood upright. It tended to be in the back of their head and went into their neck. They often also had dizziness, ringing in their ears, nausea. And so people sort of came to understand, well, this is a problem. If that fluid is coming out, then people can get a headache. But it really hasn't been until the last decade or two that an exponential increase in understanding of the concept of a spontaneous CSF leak has really come around. And where no doctor has put a needle in your back, you've not had a surgery that could have given you a CSF leak. And so we've come to realize that there's a lot of patients out there who develop these leaks, develop headache syndromes, but a lot of times not with that classic description that I just gave, that are findable and fixable in many cases.
Okay. Great. So, how do we typically find these leaks? What imaging modality is used, and what does normal even look like as we're getting started?
Yeah, this is one of the most important parts of this discussion is, where do we start, right? And really before, as radiologists or people interested in medical imaging, we're not used to thinking as much about the clinical part of things, but that's really where it starts, is somebody has to have the suspicion. Right. And for so many patients, they start, perhaps they had a lumbar puncture. Perhaps a woman during childbirth had an epidural. The anesthesiologist noticed that there was a CSF leak during that positioning of the needle. But when it's a spontaneous leak, it's the patient kind of has to find their way to some provider that recognizes, wait a second, this could be a secondary headache disorder, not a migraine, et cetera. And then hopefully then they order neuroimaging. And we start with, in general, we want to look at an MRI of the brain and just a routine MRI of the brain, nothing super fancy. And, we believe that most patients with a CSF leak will show changes on that MRI of the brain reflective of a spinal fluid leak. Those changes are sort of binned in two sort of pathophysiologic buckets, if you will. One is that the brain will sink downward, will sag downward. And the other is that the venous structures or the blood-filled structures will engorge to take up the space left by the CSF leaving the brain and spinal compartment. But the problem is that there is some portion of patients, and that percentage is debated, but there's some portion of patients who will have a normal MRI of the brain despite an active CSF leak. And this makes it even more challenging because even if the patient gets, somebody thinking, could this be a leak, or at least I should get an MRI of the brain, if the brain MRI is normal, perhaps they won't ever make it to that next step of a workup. And what's even more interesting when you think about that word normal is, what is a normal MRI of the brain? It's simply one that the radiologist wrote normal in the report, right? One of my favorite sayings from one of my old teachers when I was in training was, radiology is not a lab test, right? It's not like a machine that's counting something and putting it out. It's a person looking at images and interpreting them based on what they know, what they've learned, their biases, et cetera. So, you wonder, this percentage of people that we're saying have a normal MRI of the brain, what percentage of those perhaps have some subtle findings that were just not picked up on, et cetera. And then that normal report is now in that patient's chart, part of their medical record, and sort of stuck with them. And so if you're not, being cared for by somebody who recognizes that even despite the normal imaging, they could still have this condition, their workup often just stops there. So that's sort of the first line of how things tend to go.
Yeah. And so let's say, you have a patient who's coming in with a headache disorder. Maybe they've tried Botox injections or something to handle it. They've had an MRI, everything looks normal. Headaches aren't going away. What is kind of like the next step in trying to identify a leak?
Yeah. So, our referrals, I think, come from, I'd say there's three ways that patients make their way to me. One is, they've been working with a neurologist or a headache doctor who has been trying to address primary headache disorders, migraine, et cetera, tension headache, cluster headache. They've been trying medications directed at those disorders. They've been trying interventions directed at those disorders, like Botox is one that you mentioned, and it's just not working, right? And so there are migraines that are refractory to treatment, but that is one way, is that the neurologist just kind of reaches a dead end and says, could this be a secondary headache disorder? Or, they come in with a sort of quote unquote classic story for a CSF leak. And the neurologist, even if they're not a headache doctor, says, this sounds like a CSF leak, let me work you up, and then refer you to somebody who could further investigate this. The next way is that, a patient themselves will advocate for it and for to sort of self-refer to our program or another program because they haven't been able to get an answer for their symptoms, and they sort of do some research online and they're like, this sounds like maybe what I have, and sort of self-refer. And then, we have people who are getting worked up for something else, and incidentally, the imaging shows signs that could reflect a CSF leak. And if the radiologist is in tune with this diagnosis, sort of says this, and then they get funneled in. And for those patients, a lot of them have, what we would call atypical presentations, maybe not a classic orthostatic headache, et cetera. When you first ask them, or when their primary care or whoever ordered the study asks them, do you have a headache that's better when you lay down? And they say no. They're like, okay, well then this can't be a CSF leak. But that's a big problem, diagnostic problem, because many of these patients don't have that classic story. So once they make it to us, we make sure we get an MRI of the spine, the entire spine. The vast majority of CSF leaks that result in this condition occur in the spine. CSF leaks can occur in the skull base too, but these ones, headaches that occur that are worse than the upright position, occur in the spine. And so we examine the spine with a special MRI protocol. A routine MRI protocol is fine for identifying a big epidural fluid collection, for example. but we like to get a more detailed MRI protocol consisting of 3D, heavily T2-weighted, meaning really focusing on the fluid signal, fast-suppressed imaging that allows us to scrutinize the dura, the nerve root sleeves where many of these leaks can occur, and subtle findings related to perhaps a prior iatrogenic, doctor-caused injury, a tiny irregularity where a needle may have been, some very subtle fluid, and so on and so forth.
When you were talking about like the specialized protocol for the spine MRI, you said, I don't remember exactly what your phrasing was, something about like fat. What was the language?
Yeah, fast suppressed. So
fat suppressed. I've never heard of that concept before, like within the context of protocols.
Yeah. So, just starting from the basics, as a CT scanner or an X-ray, for example, you put the patient in and basically you press a button, it takes a picture, right? It's always the same kind of picture. For MRI, we have to ask it specific questions. We have to say,
right,
I want to look at the bone. I want to look at the fluid. And it relies on the characteristics of the tissue you're looking at to sort of ask that question. And so when you take a picture of somebody with T2-weighted imaging, that will make things that are fluid look bright, like CSF, but also fat looks bright, just normal fat in our body. And so there is fat surrounding the dura and the epidural space. And if you get imaging that does not make that fat go dark while keeping the fluid bright, that's the fat suppressed imaging, then you could mistake fat for fluid and wonder, does somebody have fluid outside of the dura when in reality it's fat? So we make that signal go away with that protocol. So we have the MRI of their brain, we have the MRI of their spine, and then we meet them in clinic and we talk to them. And a lot of these patients have really been through the medical system and navigating, seen lots of specialists. There's lots of different sort of diagnoses considered. When I meet a patient, I just want them to start from the beginning, to sort of pretend like I don't know anything, pretend like I haven't looked at their imaging or have no biases, and just tell me their story from where it began. And sometimes you'll just hear the same thing that's in the chart. Sometimes you'll discover something new. But what we're looking for in that is a sudden onset, daily new headache, usually, but not always, associated with what we call vestibulocochlear symptoms, meaning things related to balance, bringing in your ears. Patients often describe a feeling of popping, their ears need to pop, or that their hearing is muffled, vision issues, etc. We kind of get the whole timeline down. We want to make sure that have you ever had a needle in your back at all, even if you don't think it's related to this? Any spinal tap, an epidural at any time, and really understand the timeline for this. And it doesn't necessarily need to be that their symptoms started right after that intervention. And then we look at their imaging together. And for patients who have subtle imaging or even negative imaging, I like to have a conversation with them where I explain to them, look, the way that your brain MRI would be looked at 10 or 20 years ago, no one would think that there's a chance that you have a CSF leak. But instead of thinking of the MRI brain as being sort of diagnostically binary, I like to think of it in terms of a probability function, a function of the likelihood that if I go and look for a CSF leak in you, then I will find one. And if the brain MRI shows lots of findings of a CSF leak, there's a good chance I'm going to find one. If it doesn't, then I am unlikely, but it's not impossible that I will find one. When we look at the spine MRI, if the patient has a big fluid collection, then it's sort of a slam dunk. There's a CSF leak. We just have to figure out where it is. But if they don't have a fluid collection, then we're wondering, could this be a specific type of CSF leak called a CSF venous fistula? Fistula just means abnormal connection between two things. And in this case, it is between a vein next to the spine, a normal vein, plugged in and sucking the fluid out into the blood rather than a hole with fluid pouring out. And this is an incredibly important concept because this type of leak was only discovered and described around 2013, 2014. So we're talking a medical diagnosis that's really only 11 years old. And when these patients have a leak, they do not have a fluid collection and they're fine. And this is one of the reasons that this type of leak sort of evaded detection up until that point. And people were sort of dismissed. Even if they had a brain MRI that looked like a leak, there's no fluid, so it can't be a leak, right? And further, if we just do a regular sort of myelogram, where we are injecting X-ray dye into the spinal fluid, rolling the patient around, sticking them in a CT scanner on their back, maybe 30 minutes later, this is done at almost every hospital in the country, you will not see a CSF venous fistula. You have to do a special type of myelogram where the patient is on their side, where you are injecting contrast dye that is layering densely along the side of the spine. Sometimes we have to do sort of adjunctive maneuvers such as changing the way they breathe, asking the patient to breathe a certain way, raising their pressure, their intrathecal pressure. to see these little fistulas. So it's a very involved study. And this is sort of why we talk a lot about that probability of finding a leak with the patient. Because in the case where their brain MRI is very sort of subtle or perhaps negative or normal, so to speak, I tell them very frankly, look, I have found CSF leaks, fistulas, because there's no fluid collection, we're assuming in this conversation, in patients with this type of brain MRI, but the odds are against us. And the catch-22 of my job is that in order to find a CSF leak with a myelogram, I have to put a needle through someone's dura, right? And so the last thing I want to do is give the patient the disease that I'm trying to treat. And not to mention that this is an exam with a good amount of radiation. We'll do, at least usually 2 passes through the spine on each side down. So we're talking 4 whole spine CTs, maybe sometimes more. And, for patients that are younger in particular, the last thing that I want to do is have somebody come to see me. I do this test on them. I give them a post-dural puncture headache. I give them a higher chance of cancer in several decades, but then I don't help them, right? So it's very important to have this conversation to say, look, these are the risks and benefits of looking for this. And, if the brain MRI is super positive, then it's sort of a no-brainer. But if it's more subtle, we have that conversation. And then depending on whether or not, if we find something during that myelogram, that's great. It's really exciting. It's almost like magic to find these fistulas in particular, particularly for patients who've been suffering for a long time. To show that to them, it's incredibly validating. And then we could go about treating it. And there's various ways we could do that, which we can get into if you'd like. But in patients who we don't find something, then we have a conversation about whether or not it's reasonable to try just an empiric therapy, meaning we don't even see a leak, but we're still going to offer the patient a blood patch. And a blood patch is just simply taking the patient's own blood out of their IV and injecting it into that epidural space, the space outside of the dura in the spine. And sometimes we will offer this treatment to somebody where we just put blood in the spine, and sometimes it helps them. And sometimes that's temporary, and then their symptoms return. Sometimes it's long-term or even permanent, and it may be complete or partial. And there's many cases where we simply try this because there's no other therapy that's working for the patient. It is an invasive procedure, but it does not involve epidural puncture. It's much less radiation. It's low risk. I've done hundreds and hundreds of these. We've never had any serious complication, knock on wood. And so these are the sort of 2 ways that we think about as an initial branch point is, should we do a myelogram? And then if we find something, great. If we don't, should we offer you empiric treatment? Or, let's say this is somebody who's young with a brain MRI that isn't showing obvious signs. No other treatments have worked. Maybe we just start with a blood patch. Maybe we just see, if we do a blood patch, can this help you? If it does, perhaps that's a clue and gives us kind of adjusts the risk-benefit ratio in terms of the myelogram. If it doesn't at all, it's not a perfect test. They still could have a leak, but it's a good place to start in some cases too.
Cool. Not to backtrack too much, but when you were talking about the fistulas specifically, and then also concurrently talking about like iatrogenic causes of the CSF leaks, are those running in parallel, or are sometimes would an iatrogenic cause lead to a fistula, or are the fistulas pretty universally spontaneous?
That's a really good question. And there's interesting ways to look at that question. In general, the sort of general basic heuristic is that, spontaneous leaks are just that, spontaneous. They were not caused by an intervention. There's a very interesting phenomenon in a paper that was published last year where patients have an intervention that could result in a spinal CSF leak. They have a lumbar puncture. They have an epidural steroid injection in their spine. They have a spine surgery. And then they're experiencing, symptoms suggestive of a leak. So their doctor refers them for a leak workup, and a leak is found, but it's not where the surgery or needle was. It's several levels away from that. And it's a spontaneous leak, not a hole caused by a needle. And so the question is, well, how did that happen? Is it that there is something that could be triggered by an intervention in the spine, even if it's far away? Or is it perhaps anchoring bias on the part of the clinician because they say, well, my patient had an exposure to a procedure which can cause a CSF leak. They had a steroid injection in their neck, and that could have punctured the dura. But perhaps the patient had neck pain because they had a CSF leak, and they got a steroid injection for that. It didn't help. Their symptoms were getting worse, and they actually have a CSF venous fistula the whole time, right? So we don't really know. But, what's interesting further is that there's some crossover a little bit in the sense that it's been observed that in some cases of an injury to the dura, either a trauma or surgical or iatrogenic needle, for example, that a fistula of an abnormal vein can grow there and take that fluid out. one of the most challenging patient groups are patients with chronic post-neural puncture headache. This is not something that I was taught in med school, that a patient could have a headache for a long time from a dural puncture. We're sort of thought we were taught, oh, this is a benign self-limiting phenomenon. Have them lay down, they'll get better, or we'll do a blood patch and they'll be fine. But these patients could be suffering immensely after a lumbar puncture for years. And you look at their spine and there's no fluid collection. There's no, their brain doesn't show obvious signs of a leak. One of the things that I've wondered sometimes is does a fistula sort of form where that puncture was, or something related to the vasculature there that we're not yet able to see in the same way that we weren't able to see fistulas until 2014? Is there something we're missing there too? So there's a lot of questions that remain to be answered. And that sort of crossover between the iatrogenic and spontaneous is a very, very interesting one.
Well, and then what you said, it gets me, like, is there like a delay phase sometimes between, they have some sort of procedure and then they're, potentially fine for months or years before symptoms of a leak start? Like, is there ever a delay phase?
Yeah, absolutely. And there's a bunch of different reasons that could be the case. We've taken care of and published on some patients who, one patient in particular that stands out to me that I remember had her labor epidural and then years later developed her leak and we later found an injury near where the labor epidural needle was. So why did that occur? Was it worsening of the leak over time? Was it, a slow opening, for example? Did something else happen physiologically that increased pressure on that area? Was it perhaps, in the case of surgery, for example, that the patient had some bleeding during the surgery, some normal or maybe a little more than normal bleeding, which kind of acted like a blood patch, for the patient, right? In their own body, and gave them a delay in terms of then the blood patch sort of resorbed, and the underlying leak was still not closed, and their symptoms come on then. Or is there something else? Is there a compensatory mechanism that is sort of keeping people okay for a while, and then that sort of fails or something? But this is also a huge diagnostic problem. If it's not just a sudden onset right after this sort of exposure to a risk, then people have a hard time putting those things together.
Whew. Okay, sorry, I'm just taking all that in. That was a really fascinating last 10 minutes. I mean, the whole time's been interesting, but I can't believe I was trying to get clarity on the human body. Little joke there.
It's an incredible field. I think one of this has seen an incredible amount of excitement from radiologists in particular in the last several years. At every meeting that we have where we talk about this phenomenon, the rooms are more and more full. People are really excited that there is a way that we can help people, a way that radiologists can play a direct role in patient-facing care. These procedures which are novel and exciting, and there isn't a ton published in this space. It's a newer field. We can make meaningful contributions to patient care. It's not something that has been so sort of delved in and picked over, and there's huge research enterprises, things like cancer or dementia, et cetera. And so it is really exciting. It's an incredible thing to learn and about. And, the more I've done this, the more humbled I've become by this disease, the more I've been wrong. And I've just come to realize that you have to have a very open mind, about what could be going on in these people who are suffering. And as soon as you start to develop tunnel vision or sort of a way of thinking that you're sort of set in stone, is when you start to sort of plateau in terms of progress that we can make for these patients.
Yeah, for sure. To get back into the imaging process a little bit, it is my understanding that the dynamic CT myelography has been pretty central to the work you're doing. What is different about that from traditional myelography? Is it different? Is it the same thing?
Yeah, I think a good way to think about this or sort of start is to actually talk about a different type of myelography called digital subtraction myelography. And the reason that's an important place to start is because this was sort of the technique that really propelled the field forward, pioneered a lot by Dr. Shibig and Marcel Maya at Cedars-Sinai, who basically realized, well, if we use the same technique that, for example, an interventionalist uses when they do a catheter angiogram, where they're taking a live X-ray, they subtract the background out, and then they inject their dye, and you could see just the dye over the subtracted image in the blood vessel, for example, right? And and we could treat a stroke, or cardiologists can go to the coronary arteries this way. Well, if you do that with a myelogram and sort of look at it in real time, you can see the dye in the CSF, and if there's a hole, then you will see that dye come out, right? And so that is a digital subtraction myelogram, and some places do that a lot. Whereas with a conventional CT myelogram, like we kind of touched on earlier, we're injecting that dye, sometimes under X-ray. We make sure we're in, we inject it, we take the needle out, and then we have the patient do a couple yoga poses, roll them left and right. And then we just say, okay, now let's go take a CT. And if there's a hole in the dura and there's fluid coming out in the epidural space, for example, then the dye will fill that space. It will fill the space in the CSF. It'll be everywhere. And you'll look at the picture and say, well, this patient has a CSF leak, but I have no idea where it's coming from, right? I don't know where the hole is. It's the same, it's really, and there's some studies showing this, it's basically equivalent to having an MRI. You see the fluid, but where's it coming, right? And further, if you do that type of myelogram, you won't see a CSF venous fistula. So, shortly after DSM, digital subtraction myelography, was described as a tool for localizing holes in the dura, because of that temporal resolution where you could see the dye coming in and you could see the dye kind of coming out at a certain level. There's the leak, right? People realize, well, we could do this on CT too. There are benefits to CT that might be good for this study. One of the benefits is that we can look at the entire spine, right? So on a DSM with fluoroscopy, you're choosing a spot of the spine, kind of looking at it. You could have several stations that you're looking at, but at any given time, you're looking at one spot. With CT, you can get a picture of the entire spine in one run. With CT, we also can look at both sides of the spine in one day. Once you inject that contrast into the spine, and you're looking at it under a digital subtraction, once it's in there, doing a new digital subtraction, once the dye is in there with a separate injection, makes the images very unreliable and tough to interpret. So we can look at both sides. So people said, well, why don't we use these same techniques? Why not, instead of injecting under fluoroscopy and then waiting 30 minutes and putting them in the CT scanner, what if I'm in the room with the patient on the CT scanner, injecting that dye into the spine, and it's moving down their spine? We angle the patient, which is an obstacle in CT, and then take fast pictures as the dye is going down. And then we've essentially achieved what we're doing in DSM, but now we can look at the whole spine at once. We can look at places that are tough on DSM. For example, in the high thoracic spine across the shoulders, there could be superimposition artifacts if we're looking from the side. We can see that very easily under CT. And we could see any contributory anatomy. Maybe there's a little bone spur or spicule that has poked that hole, and we could see that right next to where the leak is. We could plan and treat the patient with percutaneous image-guided therapies right there on the table after the myelogram. And the downside are, there's really two major downsides. I guess three. One is the temporal resolution, right? So it's not as good as just holding the pedal down and getting that video that we're getting on fluoroscopy of the dye moving. So we're taking multiple scans to try to approximate that. And, the radiation is more in CT. It's both exams have radiation, but there's more in CT. This is definitely something that we have to talk to our patients about. And number three is this angling issue, right? Is we don't have it.
Right. That's where I was about to go.
Yeah. We don't have a tilt table.
How in the hell do you do that?
Yeah. So, I was taught to do this by Dr. Bill Dillon at UCSF, someone I consider a close friend, mentor. He's great and was one of the early pioneers in this field. But he was basically teaching me to do this we would take a hover mat, which is a patient transport device. Okay, so this is like we slide with some of the patient in this inflatable bed, an inflatable mattress, so that it helps nurses, techs move patients from bed to bed. We'd fold that in half and we'd put it under the patient's hips and literally inflate it, and they pop up in the air. So their hips would go up in the air, the dye would go down, we'd deflate it, and then we'd image. This was, it worked really well, but it's kind of horrifying to the patient, right? They come in, they've been waiting months for their appointment. Maybe they flew to you from out of state and they see, oh, what are you going to do? You're going to blow me up on a balloon? Like, this just seems very unsafe. Some people also, and I think most people probably now, not me, because I'll tell you how I do mine, but use just a foam wedge, right? They'll put a foam wedge on the table. The patient will lay on it. Depending on where they think the leak is, we'll position the patient either on their side or face down. And they'll inject that way. And that can work well, except that there's a couple problems with that. Number one, it's not a one-size-fits-all solution. Some people are very tall. We can't get that angle that we want, et cetera. Number two, if the patient has a very low pressure, which not all of them do, in fact, most of them do not, but if they do, and you angle their hips up, and you're trying to do that lumbar puncture, you've now further decreased tension on the thecal sac because now the hips are up, right? And so everything is moving down. So you're taking CSF, a dura, a fecal sac that is already under low tension, and making it under lower tension, getting your needle in to get a diagnostic quality exam is very challenging. And you cannot measure an opening pressure in that position when they're up. It's not a reliable measurement, et cetera. So having a way that we can start them in the flat position, do our lumbar puncture, do what we need to do, then raise them up in a controlled, safe way, like we could do on a tilt table under a fluoroscopy, for example, and then bring them down if we need to, is imperative. And that's why, we developed a patient positioning device for myelography, for the CT table. We call it the Myelovator, myelogram and elevator, get it? And essentially it is nothing super fancy. It's a very simple, I think, kind of elegant. It is simply a fiberglass frame, essentially, with reinforced polymers that has a hand operating winch that basically has two sides of the table. And as I crank that winch, there's a strap that pulls one side of the table close to the other. There's a hinge in the middle. And this allows us to tilt the patient in a very controlled, precise manner. And so I use this every day. We've done hundreds of exams with it. And I could really sort of control where the dye is going to go. I could keep the needle in the patient when they're flat and then slowly raise them up into where I need them. If it's not high enough on my first image, I could bump them up a little higher. If it's too high, I can move them lower without sacrificing the sort of overall quality of my exam. So that's how we do it.
That is cool. Sorry, I don't have a cool follow-up question besides that's cool. You had to invent your own device to image patients in the way that you need to. So it seems apparent to me that running a CSF Leak program is a slightly different day-to-day compared to reading just like routine neurological studies. Can you just talk about how this specialization has kind of reshaped your workflow as a radiologist?
This is, I think, frankly, there's a lot of obstacles to patients getting appropriate treatment and getting worked up and advancing this field. But I think that these systems-related issues are really one of the most critical and important to talk about. So, radiologists did not go into radiology to have clinic, to see patients, to do procedures all day, unless they wanted to be an interventional radiologist, right? But diagnostic ones really no. And further, the economics of what I do are not favorable for my department, right? So, taking a neuroradiologist out of the reading room, neuroradiology is a very, relatively well reimbursed field in terms of how many RVUs, each study we read is worth. And for a department as a whole, it's a good, it really supports the department financially. And taking me out of the reading rooms, reading studies all day, and having me be in clinic or do procedures, which, while very sort of time intensive, require a lot of thought, are often very advanced, don't really have advanced procedural billing codes to accompany them. When I do a dynamic myelogram, I'm billing like I'm doing I'm not billing anything, but my hospital's billing like I'm doing a regular myelogram. And my department did me the favor of calculating, how much money exactly am I losing for the department? And it's about 60%. So I'm losing about 40% for me, right? So taking me out of the reading room and having me do CSF Leak full time, which is basically what I am, is, basically 60% of the RVUs that compared to a benchmark neuroradiologist, right? And my days are packed. I mean, I start seeing patients at 7 and I go all the way 10 hours in a row till 5 p.m. and with no breaks. I'm working very hard. In fact, I think I'm working harder than I work when I'm in the reading room, but it's way less, right? And so what we have to do as a specialty is, first of all, figure out ways to code for and bill for this type of work appropriately. But also the way that we've been successful, the way that we've been able to do this work despite that, is to think outside of radiology, right? This is not just radiology. This is something that involves neurosurgery. It involves neurology. These patients that come into the health system, your health system, are going to ping off multiple dimensions of that system. So what I did is engage our hospital leadership and say, listen, I want to do this work. This work is important work. There's not a lot of places doing it. It's bringing in patients who are not otherwise in our system, new patients, new business, right? For you guys. But my department doesn't want to lose money for me doing this work. We need to find a way that you are getting compensated well for these new patients. My department's losing money. That neurosurgery has a similar problem. The sort of these leak repairs are very complex, but a lot of them don't have advanced billing codes. And so, how do we navigate this? And we've done so by sort of teaming up in a multidisciplinary fashion and also with administration, with leadership at our hospital to say, how can we create a financial model that makes everyone whole? I'm not trying to get rich off this or make more money than I would otherwise, but I also don't want to lose, 40% of my salary because I'm doing this work. So, how do we make everyone whole, make our department not lose money and still see the benefits and still sort of advance patient care? So but this took years, to get to where we are now. And it still is a struggle. And it's something I talk to a lot of my colleagues at other institutions about. They're like, how are you able to do this? Or in private practice, forget it, right? I mean, if you're a radiology private practice, it's all about volume, RVUs, productivity. They're not going to take somebody out to lose 40% of their productivity to do this sort of specialized thing. I mean, so we need to figure out systems related obstacles and overcome them if we want to see that this field move forward and the care of these patients advance. And I do think that in 5 or 10 years, or maybe even sooner, most tertiary care centers, most academic medical centers will have a program like this, because these patients are out there. It's considered a rare disease. I do not think it's rare. It's certainly not rare to me. And I think that and as that sort of growth happens, we're going to have to figure out these sort of logistical and systems related issues.
So the first finding of a CSF venous fistula was, you said 2013, right?
Yeah. So it was found in 2013, published, written up for the first time in 2014. Yep.
Okay, right. So we're like just 10 years into playing ball with this field. And, you were talking about 5-10 years in the future. You think more and more facilities are going to have programs for this. But like, where else do you see, is field specialty, what do we want to call it? Like, where do you see it going and growing?
Yeah. So, the first way that I see it going and growing is simply in recognition. Right. So with this entity, the CSF venous fistula was described, everyone's like, wow, look at this crazy, rare, unusual thing that probably never happens that frequently. Now, this is the majority of leaks that I find, right? This is what they are. And these patients are out there. They are everywhere, that walking around misdiagnosed with migraine, with some other pain syndrome, et cetera. So just the recognition that this is not something that's super unusual that we shouldn't be thinking about. That's number one. Number two is, in what we talked earlier about having an open mind, thinking about the things we don't know. I think there is still so much work to do. One of the best part of my job, the thing that brings me the most professional joy, that gets me, still as excited as the first day, is finding someone's leak, especially when their imaging wasn't very suggestive, validating what's been going on for them and helping them, right? And equally, the most challenging and frustrating thing for me is when I can't help someone. When they've seen a bazillion other doctors, they have no diagnosis. Perhaps their story even sounds exactly like a leak. It's like a textbook. It's like they just read out a textbook, right? And I find nothing. And even an empiric therapy doesn't help, right? There is a subset of these patients who we do not have answers for. The medical system has failed them, that are trying to advocate for themselves, often, engaging in treatments or therapies that are not evidence-based because they have no other answer and they're suffering so much. And because the clinical phenotype of a lot of these patients does resemble a leak so much, I think there is something else big that we are missing, that we will come to understand about the pathophysiology of both the cerebrospinal fluid and the surrounding venous compartment, and that may be another leak type that we'll discover, just like the venous fistula, or something leak adjacent, something that could cause the problems that look like a leak clinically and feel like a leak, and a way that we can sort of help these people, because that is a huge, huge problem. These people are suffering a lot of times in silence, unable to be a mom or a dad, unable to work, and they're desperate for help. And we as a medical community have failed them by not giving them an answer. So it is those patients that I think about when I think about the future. I want there's got to be an answer for these folks, and that's our job to figure it out.
Beautifully said. With that, I believe that is all the time that we have for today. Thank you so much for joining us, Dr. Callen. Once again, Dr. Andrew Callen is the Associate Professor of Radiology and Neurology at the University of Colorado School of Medicine, as well as the Director of the CU CSF Leak Program. Dr. Callen, thank you so much for joining us here on Frame by Frame. It's been great having you.
Yeah, thanks for having me. It's my pleasure.
Frame by Frame Rethink Imaging is brought to you by Immunologics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Immunologics is rethinking imaging and healthcare, visit Immunologics.com. Be sure to subscribe to Frame by Frame Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Immulogics, thanks for tuning in.